Hello, I'm Dr. Alan Siegel, and I want to welcome you to today's important conversation, The State of Social Prescribing in the U.S. 2025. I'm a practicing family physician at Kaiser in Oakland, California, and also the Executive Director for Social Prescribing USA, the host for today's webinar. Social Prescribing USA is the primary national advocacy organization for the adoption of social prescribing in the U.S. Professionally, I have used social prescribing within my practice for the last 25 years as it allows doctors like me to more fully be able to address our patients' needs using all the tools we have in the toolbox. For example, rather than being limited, as I am, to just therapy and medication to address mental health and loneliness, let's use the gifts of the arts, nature, movement, service, and connection as critical tools that need to be part of our healthcare across the US. That is more of the healthcare system I want for my children and their generation to inherit. We're here today for many reasons, none more important than to celebrate International Social Prescribing Day, along with 31 other countries around the world. This day was launched in the UK 7 years ago by our friends at the National Academy of Social Prescribing. We have the benefit of learning from others who have preceded us in the field of social prescribing, including scaling implementation nationwide. The US has a complex healthcare system, and social prescribing will likely look different here, including many models across the states. But our complexity will not stop us from striving to be a global leader in social prescribing. Last year, we had our first celebration of Social Prescribing Day, and since then, it's been a significant year for the social prescribing movement in the US. It has received tremendous attention in the popular press, and our former Surgeon General served as a great advocate for the field as he was focusing on the loneliness epidemic. At Social Prescribing USA, we heard of an increasing number of organizations that want to bring the practice to their communities. We heard of physicians who were exploring the field, health systems that were integrating efforts into operations, and patients whose lives were improved by social prescribing. All the attention and energy were incredibly exciting. We know there is much more work to do here in the US to reach more people in more states with social prescribing. And I'm proud that Social Prescribing US is working with advocates around the country to make this happen, to address challenges, and to grow this movement through an increasing community of practice and health champion network, together more than 300 people strong and growing. We want 2025 to be a big year for the movement and 2026 to be even bigger. This year, we're developing a mapping project for the US social prescribing programs. We're working towards convening later this year and hosting a full US conference in the fall of 2026. We're also collaborating with the Benjamin Goldberg Foundation on a toolkit to support local summits around the country. Just as a sign of how the movement has grown, we know that social prescribing efforts are taking place on more than one day this week. I'll be part of a panel on Friday with our friends at the Federal Reserve Bank of New York, providing another snapshot of the field. And following this webinar at 5 p.m. Eastern Time, we're teaming up with Jules Hotz, author of The Connection Cure, for an all hands-on, a time to brainstorm one action you can do to help spread social prescribing. You can learn more about these and other events on our website at socialprescribingusa.com and visit our Social Prescribing Day 2025 page. And now on to today's program. We're excited to hear from some of the leaders in the field about the state of social prescribing in the US, what's happening and what still needs to happen to make social prescribing more mainstream within US healthcare. To lead the next part of the discussion, I'm happy to introduce today's moderator and my friend, Tracy Paris Benjamin, a great social prescribing leader. Today, Tracy is the managing partner of the Outcomes Architect, an advisory group that works across sectors to use data, technology, and policy to improve corporate outcomes. Tracy holds a distinguished record of healthcare innovation and transformation with the primary goal of achieving equitable health for all. Before her current work, Tracy was the director of Health Equity and Community Equity for Horizon Blue Cross Blue Shield of New Jersey. While there, she led a pioneer partnership with the New Jersey Performing Arts Center, which is one of the first arts prescribing programs in the country. Since then, the arts have really taken the lead on promoting social prescribing in the US. I think it's fair to say that without Tracy's work, the social prescribing movement in the US would not be where it is today. So with that, a sincere thank you, Tracy, not only for being our moderator, but also for playing such a role in building social prescribing in the US. Tracy.
Thank you so much, Alan, and good afternoon, everyone. What a pleasure it is to be here today. I'm so excited to moderate this. We have a group of esteemed panelists that we believe are going to provide us with insightful, innovative information to help us continue to pass on this movement, to make sure that people don't forget about this work, especially the environment that we're living in right now, where so many things are polarized. It is important that we continue to incubate ourselves with leaders that are doing this work. Sometimes we forget how important it is to have social gatherings, and I really see this as a social gathering. While we're providing information, it's important that we make sure that everyone has an opportunity to have questions answered. There will be a chat that will be open, so feel free to ask questions. You don't have to wait till the very end to get your questions out. We want to make sure that we not only hear from our panelists, but we hear your questions because that will be insightful to us as well. One of the things that was really so imperative and important for me when I led Horizons program was incorporating community health workers. Community health workers really served as I would say, really kind of the driving force behind this work. And what was important is to make sure that the social connections were a part of the medical healing. I see this as an opportunity to provide what I believe is comprehensive health and wellness altogether. So not just the traditional, but really making sure that the arts, whether that is from a perspective of our general social prescribing, which we think of as food and transportation, but beyond that, connectivity, the arts, whether that's music, and we all know the connection that that has. So without further ado, I would love to be able to introduce our esteemed panelists, and I'll ask them to just give us a few words about who they are before we dive right into the questions. So I'd love to open with Camilla.
Thank you, Tracy. Thank you, Alan, for inviting us on Social Prescribing US. Camila Ronderos, I'm the Executive Director for Carol T. Compassionate Communities, which is a nonprofit that works in bridging the gap between healthcare and communities by helping organizations incorporate social prescription and loneliness assessment to their practice, but also empowering communities to understand that we can do social prescription at the local level and also build stronger, more connected communities as well.
Thank you, Camilla. With that, I'd love to pass it over to Dr. Czar.
Well, thanks for having me. It's a pleasure to be here, and welcome to all the panelists and all the audience as well. I'm Robert Czar. I'm a pediatrician by trade, as well as I like to think of myself as a public health professional, and have been practicing for many years now. I guess more than 2.5 decades. I'm losing track of time. And for the last 15 years, have really embraced this concept of what initially I was introduced as PARC prescriptions, and now I've sort of broadened it to nature prescriptions. Being a pediatrician, I was first introduced to this concept of prescribing nature through the work of Richard Louv. And it's taken on many different shapes and forms. I'm now the founder and medical director for a nonprofit organization called PARC RX America, which, if you care to find more information about it, at natureprescribed.org. And our primary focus has really been to reach out to the health professional community, of which there are about 18 million health professionals in the US alone. And so far, we've had a pretty robust interest, I'd say, over the last 5 to 10 years. We now have about 1,800 providers, almost 1,900 across the US, and a few countries across the world who've joined our community and our platform to incorporate nature prescriptions into their daily routines. I'm also involved in research, I'm involved in advocacy, and we have a lot of partner organizations that has really helped promote not just nature prescriptions, but really more broadly nature interventions, or nature as an intervention in multiple kinds of settings. Thanks so much.
Thank you, Dr. Czar, and I'd love to pass it over to Lenny.
Thanks, Tracy. My name is Lenny Knowlton. I'm a certified mental health counselor out of Salt Lake City, Utah, and I'm the founder and executive director of Project Connection, which is a nonprofit mental health agency. So we have a clinic. We have about 45 therapists. We have a clinic, and then we run a bunch of social and therapeutic integration programs. So we have contracts in 25 Salt Lake County schools where we provide therapists on staff, and then we can provide recommendations for integrating therapeutic work into school systems and also some other community health organizations. And then we run a mental health social prescribing organization where our therapists have the ability to refer our clients to link workers that also work at Project Connection, who are connecting them in really meaningful ways, doing assessments and connecting them with community organizations for social prescribing interventions. I've also worked over the last couple of years to found and put out what I'm calling relational social prescribing, which is a social prescribing method that really focuses on the importance of relationships within the within social prescribing. It's a model that we have adopted at Project Connection, and incorporates the things that I've seen really impact mental health. And I also work with Social Prescribing USA and run the community of practice there.
That's a lot.
Yeah, it is a lot.
In a good way, in a good way. And last but certainly not least, I'd love to introduce Carla.
Hi, my name is Carla, Dr. Carla Perissinotto. I'm a geriatrician and palliative medicine physician. I am also a researcher that has been looking at the effects of loneliness and isolation in older adults. I think, like Alan, I have informally socially prescribed as a clinician for years without really having a term for it. And most recently in my work, really thinking about what a formal social prescription process would look like. I think, as everyone has shared, and as we'll hear more from organizations, many of us are either socially prescribing or have organizations that would be used in social prescribing. The question is how do we have the evidence to match what is the right prescription for the right person and for the right problem? Thanks so much. And I will also have the caveat that I have a loaner laptop, so it looks like the way I'm looking at it looks like I'm looking down, but I'm actually looking at all you because I don't even know where the camera is on this thing. So anyway.
It's all good, Carla. We're glad that you're here.
Thank you.
Best laid plans, right? It's always
Yes.
like that. And Alan, I know that you've introduced yourself, but you're definitely one of our panelists. Before we go ahead and dive right into the questions, is there anything that you'd like to add? Oh, Alan, if you're speaking, we can't hear you. So sorry.
Yeah. I am presently at Kaiser, and we are exploring within Kaiser what is possible to do in social prescribing, which is very exciting. And we've been working with people all over the country, and so we're just really excited to have a lot of people here, and for all the people who are joining this movement. It's definitely going to take all of us to be able to make this happen. So welcome, everyone, and thank you.
Absolutely. And it's important that we continue to voice what social prescribing is so it catches on and it becomes something that's ongoingly viral. So I'd love to dive into some of these great questions. And guys, please feel free if there is something that you want to add on to what someone else says, please go ahead and do that. So what does social prescribing mean to you? I think that's really important to just make this a little personal. I'd love to hear from each of you. Some of you have mentioned already that you've been doing this for quite some time, but just tell us in a few words, what does it mean to you? And we can open the floor to anyone.
I'll start. So I think I might be one of the odd duck here because I am actually an anthropologist by training. And I started working in a nonprofit of a healthcare organization. So when I came here and I started telling people, my grandfather was a doctor, and I think he socially prescribed forever and ever without even knowing it. He's of course not no longer with us. He was very old, and I think that when I came to the healthcare sector currently, I was amazed of how little we were connecting to the true lives of our patients and to the true needs of our patients. And so as an anthropologist, I started questioning the teams around me. Are you truly asking what you need to ask, or would you just focusing on the conditions and on the diseases? Should we be talking about something else with our patients that is maybe even more important? And so for me, it was like something very close to home, because that's how my grandfather taught me medicine should be. And then my training as an anthropologist complemented it. So for me, it was about helping doctors realize that doing true healthcare was stepping a little bit away just from the disease and understanding the true needs and worries of our patients, and then figuring out how do we connect them to things that can help them truly feel better. And I think that's how I started in the company. Not the most famous person at the beginning in the company, but I'm getting there.
Yeah, thank you for that.
If I can add, Camila, I am also an anthropologist by training. That's what was my undergraduate degree. And in very much, I think what shaped me going into medicine, I knew I wanted to be a physician, but I always saw health in the context of broader social, cultural, political forces, which may be even more relevant these days as we become more disconnected. And so I think for me, as a clinician, as a community member, as a person, just recognizing that health is complex, and and often as a clinician, I probably have more power in the non-medications that I prescribe. My practice is actually only in home-based care, so I only see people at home. And in those environments, it allows me actually to more effectively, I think, socially prescribe by recognizing what's in someone's environment, what's around them. And I think when I think back to my early patients, when my social prescription could have been as simple as someone moving from their old hometown into a new assisted living facility and wanting to find new bridge partners. And I would literally write that on a piece of paper, like, between now and when I see you next, because that is what's important to you, I would like you to think about who your new bridge partners are. And then maybe explain to me at a later date what bridge is, because I still don't know what that is. But so that is what I do on a daily basis in trying to find that. And then fast forward, as someone else said, recognizing, I think, Lenny, as you said, social connection and how we connect to others is so integral. And we've seen that in the Surgeon General's work and work that we've done nationally through the Foundation for Social Connection. Is like, what are those ways to connect? And in another way, sometimes that social connection that is needed is more a connection with ourselves, to understand ourselves before we connect with others.
Yeah, I love that. Thank you, Carla. Anyone else want to add anything to that?
Yeah, I can rumble. So my history is in community mental health. I started off working for the Division of Child and Family Services and doing high trauma work. And so back when, I was in my 20s and had absolutely no business doing any of that or making any of those decisions. But through working with a lot of people over time, people who've experienced a lot of trauma, working in people's communities, in people's homes. Yes, I'm a therapist and I believe in therapy, and I think it's such an important piece of mental health. But therapy is where we make the map. It's not where we actually heal, right? Where we actually heal is taking the work that you do in therapy, which is generally what people come in is for some kind of disconnection, right? I'm having an issue with my partner, an issue with my mom, an issue with the workplace, right? And we make these maps about the things that have happened to us and who we are, and then we have to practice it. We have to take the work that we're doing inside of the therapy room and take it outside into our world and into our lives and integrate that in order for that to be effective or to have impact. And so when we founded Project Connection, it was a no-brainer that yes, we were going to have therapy, but we were going to have it combined with these different ways for people to practice and write, and social prescription is the way that we practice how to navigate and how to navigate the work that we're doing on ourselves into our lives. And I just would preach, and my mission is that there's these kind of separate things where there's mental health, and then people talk about loneliness, and they're funded differently and they're talked about differently. But my biggest thing is that connection is the foundation of mental health. That, as humans, we didn't get to be the the dominant species on the planet because we were the fastest or the fiercest. We got to be the dominant species because we learned how to master the tribe. We learned how to work together. We learned how to feel safe when we are offering and when we're a part of community and when we are working towards a common goal. And so just bringing those in together and saying that if we are wanting to talk about acute crisis, if we're wanting to talk about suicide prevention, that really like taking this message and integrating it into social prescribing and connecting people with things that matter to them and with each other and giving them a sense of security in those organizations is like really where it's at.
Yeah, I mean, all great answers. I love that idea of mapping and connections and, just self-awareness. I think those are kind of the themes that kind of stood out to me among all of your answers. I think another part of this that where I'd like to go now is just what is the current state of social prescribing for you in your, within your jurisdiction, whether it's in your community or even in your workplace? What is that like for any of you at this time? If not, I'm happy to call on like students.
I'll jump in. And in fact, I think I would like to say a few words about what social prescribing is to me before we kind of dive in up further on the next question, Tracy.
Mm.
For me, I would say as a practicing physician for so many years, as somebody with this sort of public health minded perspective on things, I would say maybe one of the best ways to define social RX or social prescriptions really gets down to the conversation that we are having with our clients, with our patients. And it's not the kind of thing that most healthcare professionals do. Um, and I mean that because oftentimes we find ourselves, pressured for time, whether it's the hospital or the clinic setting, and we're trying to get as much done as possible, and it ends up being a very pressured visit for both the provider and the client or the patient. And social prescription really sort of flips this idea of an RX or a prescription completely on its head and says this isn't about, the provider telling a client what to do. It isn't about us dictating that this is how you're going to live your life, but it's really about as a provider community, understanding the social and physical determinants of health, going back to public health. And those are things that I think all my fellow panelists understand far better than I do. But knowing where our patient lives, asking questions about whether they have food insecurity or not, asking questions about whether they feel safe and secure, asking about sort of their daily routines. These are the kinds of questions that require a conversation, and a conversation that leads ultimately after about 2 or 3 minutes, because that's about all we have, to an action, right? And that action ends up being the prescription itself. And the amazing thing about a social prescription versus a medical prescription is that it's co-produced. And that to me is something that I've learned over the years is probably the best way to explain to people like, what's the difference? What are we talking about here? It's about a conversation that doesn't have to do with medicines, let's say, or referrals to specialists. But it's a conversation that's sort of prompted by a series of questions and listening. That can be done very quickly, and it can be a brief intervention, but ultimately results in an action, a decision that's made. And it's a decision that's come to between two people or between a family and a provider, that is within the realm of possible for that person or for that family, which is so different than what patients or clients usually experience, which is, wow, okay, you want me to take this medicine? I can't afford it, or I don't have a place to do what you asked me to do. You told me to eat better and exercise. That's usually where it starts and where it ends. So it's a sort of really rethinking and revamping the kind of relationship, and connection was the word my fellow panelists were using, in order to bring about an improvement in health. And I mean health in a very broad way.
Yeah, no, I really appreciate that. I think that's a great observation. And even before I go to the following question, you prompted me to think through how do we get clinicians, more comfortable with doing what you just described. Myself as a social worker, I've said this before, I've always done that. That has always been a part of what I do. That's what I've learned, but for clinicians who want to fix and help their member patients, clients feel better, what do you think is what you say, the miracle to get clinicians to start, treating patients that way and having that dialogue?
Well, I'm going to jump right in again, and I'll start this time rather than end. I've been asking myself that question for 15 years, and I've been taking, different approaches over the years. I think when I initially approached my colleagues around the country and around the world, I had this sort of youthful enthusiasm that this was just going to take off, and it wasn't just going to be popular in the press, but it was going to be something popular among my colleagues who were going to embrace this. And, I thought there was enough evidence out there already that spending time, at least for my kind of work in nature, because I do nature prescriptions, was enough. But clearly it's not. And we're not seeing it take off in the way that I had wished it would 15, 20 years ago. And this leads me to my current hypotheses. And one of these hypotheses really is that if we're asking a radical shift, a radical change in the way that healthcare professionals do their job, I think we've really got to think about those healthcare professionals themselves. And what is their culture like? What is their day like? What is their stress like? What fatigue are they experiencing? What nature deficit are they, in fact, experiencing? What kinds of moral injury are they experiencing every day? And then it sort of, I think, lends to a better understanding of maybe why this hasn't taken off. Because my opinion so far, and some of it's based on some data we've generated through some survey research, is that there does seem to be a correlation between providers who really take self-care seriously, providers who take breaks, providers who have a healthy relationship with nature, providers who spend time in nature, and the propensity to integrate these nature prescriptions into their practice. So this leads me to believe it's not a causal relationship that I can prove yet. I think it does need to be researched more, very much more, in terms of the implementation science of social prescriptions, and specifically in my work, nature prescriptions. It'll help us to understand why this hadn't taken off yet. So I'll stop there with that.
Yeah, no, that's great. It sounds like the prescriber needs to become the prescribee in some ways. Yeah.
I would add, I really appreciate that, Robert. And I think there's a couple things too. One, excited to share that, our research group at UCSF is actually doing some implementation work on social prescribing. So you may hear more if you're interested in being part of that process. One of my team members will join, and please feel free to reach out so you can be a part of those focus groups and interviews as we develop some processes there. But two, the way we're trained in medicine is still very on a biomedical model. And there are still a lot of clinicians in different fields that don't believe it's our responsibility. That it is, you refer to social work and they will carry it out. And then what I see by my social work colleagues is, old person's lonely, send them to a senior center without actually understanding what is at the root of that and whether someone can actually get there and whether that's actually what they want. And so there's a fundamental problem with our medical training. I'm going to focus on medicine specifically. Whose responsibility? And then the ugly word in the room is burnout, and the fact that, I will air it out here that I was up till 1:30 in the morning charting last night. And so you have that part. And then there's also this sense that, again, in the biomedical model, that usually it's like, oh, high blood pressure, let me give a prescription. I know what the data is. We also often overestimate the data that we have in medicine and make it seem that it's better than it actually is. And so then you also then try to convince clinicians to say, hey, prescribe the arts or et cetera. And they're going to say, show me the data. So there is this part as a skeptic that we do as this field need to show the data so that we can say, and I can say that I know, for example, for social connection, I can tell you that we have data on peer programs to show that that is actually beneficial for loneliness and social isolation. So let's move the field forward in this amazingly abundant federal funding landscape to do what actually matters for our communities, ourselves, and our patients.
like to jump in too. So I said I'm an anthropologist, which I am, but I also work for a healthcare organization. I mean, my nonprofit is part of a global healthcare organization called Carolty. And I guess I'm one of the lucky ones because my organization actually thinks that the only right way to do healthcare is to incorporate a social and community approach to whatever we do with our patients. And so I don't have I mean, I have the struggle of convincing certain people in my organization that this should be done this way. And oddly enough, it's not the management because the management sort of is the one pushing this. It's been harder to convince the doctors and nurses and the teams on the ground. And I agree that there has a lot to do with burnout and with how much work they have to do every day. But I also think that they don't know how to address this because doctors, as Carla was saying, are trained differently. And so they understand numbers and they understand, having that conversation is not something that's common to them. And so when I started implementing within the Carolty system, and Carolty was born in Colombia, I'm actually based in Colombia, but I run an organization here and in the US. And so when we started both in the US and in Colombia to do this, I kind of assumed that the doctors were going to be able to talk to our patients and figure out what they needed. I was so wrong. And so I decided to start looking for a simple number because I realized that you guys know numbers, right? So blood pressure is high or low, your diabetics, your measurements, that's what you guys know. So I said, well, what if I come up with one simple number that can help them start the conversation? It was just kind of an excuse. So we decided to use the Lubin scale, which is a loneliness scale or a social connection scale. There's many others, but this one only has 6 questions. So it made it quick and easy for the little time that you have in the visits, but it also allowed us to have one number. And something magical happened because once they had the number, it wasn't so hard for them to address it because they didn't have to figure out how to get to that number. They had the number that opened up the conversation. And so once they saw that you were 12 or under, which is the cutoff number for the Lubin, they would talk to the patient. They would be like, oh, I notice here that you don't have as many social connections. Would you like us to try to connect you to something different because this is so important for you? So it made it easier to start that conversation. And of course, we have community health workers within the facilities of both Sanitas in the US and Sanitas in Colombia, where they're constantly looking for resources outside in the community. Our resources are not just green or nature associated, they're in general. We find things in the community, the bridge group, the group of men that sit in the corner and play dominoes, the group of women that sit in a coffee shop and do knitting together. Because at the end, for us, it was about connection and connecting to others. It wasn't just about the nature. You could connect anywhere. If you like knitting and you don't like bugs, then you're not going to go outside, and that's fine too. And so, or the heat of Miami, which is where our offices are based in the US. And so, what we did was bring those resources into the medical facilities so that it made it easier for the provider to be able to socially prescribe them. In Colombia, we even managed to embed them into our EMR. So if you click on the resource link, the resources will pop up for a woman of my age in the area surrounding the medical center. So it really makes it very easy for the doctors to do it. We just try to simplify it. But what I think is wonderful today, many years, like 5 years after we've started doing this, is that today we see patients that are getting social prescriptions that do not have a Lubin. Because now that they're doing it systematically, thank you to the Lubin, they've gotten sort of in the role of understanding why this was important. And so now I would say about 50% of the social prescriptions we get do not have a Lubin associated. So they're not being measured officially by anything. The doctors are now being able, 5 years later, using the Lubin, they sort of got the hang of how to connect differently to the patients and how to start a different conversation. And so now it's actually part of the workflow without me having to force it as part of the workflow. We just gave them first a tool that they could use. And in Colombia, for example, last year we did 150,000 social prescriptions, and in the US we did about 5,000 to 6,000 social prescriptions. We're smaller in the US. In Colombia, we're much bigger. And so at the end now becomes part of the routine of how to do it. I just think that they also need help on how to start those conversations,
Right.
because there's not a lot of training. And also understanding that social prescription is not just from the provider side. Anyone should be able to do a social prescription. I could do a social prescription to a friend, which in other places are called connectors. Because at the end, since it's not a clinical thing, we all know things that could be helpful for someone else, a group of parents, if you're a new parent, and something that you already know. And so it was also about opening it up a little more about it's not just the doctor that can do that. It's anyone in the facility. So we have PRCs, the people at the front, sometimes doing social prescriptions as well, just because they notice in the conversation that it could be useful for our patients.
Right. And Camilla, you touched on so many different areas. I mean, I have quite a few questions, remaining, but my mind is kind of spinning just to keep the conversation going because I think one of the things that you touched on was, challenges, which Dr. Czar touched on as well. But I also would love to know a little bit more about, how do folks see extenders beyond that? So I heard link workers, community health workers, because while we're definitely talking about physicians being burnt out, I think across the board, anyone who's doing any kind of public health field is probably burnt out. I was recently at a presentation where we talked about creating pathways, creating, career advancement for those of us that are doing this work. Like, how do you pave the way for the person that's after you? So, for example, as you're talking, Camilla, I'm thinking about all the work that you do. Who's the next Camilla, right? That will be able to do this work, right? Who's the next Dr. Czar? So I'd love to hear from you guys personally. Like, what pathways are you creating to extend this beyond, yourself for others in the field, whether it's other clinicians, community health workers, link workers, social workers?
I'm sorry, I read Carla's message that I think living in the US is causing burnout, and I couldn't help laugh. Um, sorry. In our case, for example, we do constant training to all of the physicians that work within the Sanitas facilities. Because of course there's high rotation of physicians, but and so when we train and retrain, sometimes someone asks me, aren't you tired of doing retrainings every time someone leaves? And I'm like, no, because the person that left took that hopefully to the new place where they went, and they have started doing this. And so for me, it's kind of sort of being able to spread the word. Also, in line with what Carla was saying, I think the training for for the students should be incorporating this. And so in Colombia, we have a university, for example. And so we have incorporated in our university in Colombia, we only teach medical trainings. We have medicine, nursing, and psychology. And so all of our students within our university in Colombia are getting trained around social prescribing as part of what they do in their everyday life, or what they should be doing in their everyday life. So at the end, I think it's about getting more people to champion this within their own facilities, and then from there take it to other places. And so you know how high the rotation of doctors and providers is in the US, and it's been in the news. And in our case, I think in my case at least, while my company doesn't see it that way, I see it as a way of spreading the word that this could be happening somewhere else. Also participating in things like this and other little things that we do, like throughout the year, participating in different settings where we start also talking about how social prescribing should be done within the community. And one of the things that we do is work directly on communities with community leaders, because they can do social prescribing too. They can identify the needs of others in the community and then connect them to other resources. And so what we have done is in our case, we created a website, which is where all of our community health workers put in the resources, because all of the resources that are there are vetted by us and have an official phone number and contact person, because it makes it easier. It's not just like go to the Parks and Recs page and look for it. It's go to our website and you will find a vetted resource in your area that you can contact. And what we try to get is community connectors that from there start connecting others through that website to those resources. So it's not just about training sort of that medical or health side, it's how do we make it more democratic as well in terms of access.
Sure. Lenny, anything that you'd like to add? I know that if you work in the mental health space with social workers and other clinicians.
Yeah, I mean, going back, for me, one of the biggest things that makes a huge difference is that link worker and assessment piece. Right. And even in running the community of practice for Social Prescribing USA, like I think everybody there's, hundreds of people on this call, and everybody's here because it just makes sense, right? Sometimes people describe the social prescribing movement as like something new and like innovative. And I would argue it's not new and innovative at all. It's like, in this thing I wrote, I described it as like, remember in the 90s when we were supposed to be healthy by having everything fat-free, like Olestra and margarine and all of these things. And then at the end of the day, we realized that wasn't working and we probably should just go on a walk and eat broccoli. Like, I feel like that's where we are. And there's this part of when people talk about this that just resonates. Like, yes, I know that connecting with others and being healthy and having these engagements is good for me. And so we're looking at, clinicians and doctors, prescribers, and people are like, yeah, I want more than this. I want the capacity to create more than this for my patients. And I want opportunities for my patients to try on different things. And then we have so many people, so many nonprofits, so many people who are talented and they find, music or, connections or a game or a community that have, saved their lives and they want to recreate that. And for me, the magic has been really in this link worker space, right? And if you look at like the UK or other organizations where things has really taken off, that's the magic. Like they have that, right? It takes pressure off of the referring clinician and it gives time for assessment. I think that assessment is so key. Sometimes we'll say, oh, like we love art, so everybody should love art. That should be good for everybody, or like, I love to play bridge, so we all love to play bridge. But at the end of the day, there has to be meaningful assessment that says, what matters to you. And the recipe that we're finding in the research that we've done that I'm, incorporating into this relational social prescribing is that the magic happens when you are connecting with somebody else or other people around something that matters to you. And then you have the capacity to feel like you add value to that thing. And that is a huge thing that I think we're missing, right? Like if you're a cave dweller and you don't feel like your skill set matters and you can be ousted from your tribe, that you're not big enough, smart enough, fast enough, strong enough, and you get left behind, you're dead, right? That is the basis of anxiety. That is the basis of depression. And so we always think in this US system, like, what do we matter? We're going to throw out these resources. Do you need a house? Do you need food? But at the end of the day, like, do we treat people like people and say, like, what system do you want to be a part of? Like, what matters to you? Like, where do you, want to freak people out, ask them what they have to offer. Because that is a question that people, deer in the headlights. And so I really think as we've developed our link worker and we've navigated that system by taking, the standard social worker code that I can bill through my practice, which right now is, it's a T1017 code that you can bill anything that is coordinate, assess, link, and monitor. And in our system, it's really been just utilized for resources. But like, if you look at the work of social prescribing, that is exactly what we're doing, right? We're coordinating and assessing, linking, and monitoring. I also think that there's this value. We say, oh, there's a resource, go get it. And we're not accounting for social anxiety. We're not accounting for the barriers that actually get people to the thing. I know that I'm, uneducated, upper middle class, whatever, but I'm not going to the first time that I go to a new workout class by myself because that is damn scary, right? I'm calling my friend and saying, hey, you want to come with me? And you walk in and you kind of like share that thing. So the idea that we're just saying, oh, you should find this thing online, you should go do that and meet people is just, a lot of times it's making sure that the people that you're referring to them are trauma informed, that you're going with your arm around them and saying, hi, this is Nancy, and she's got you, right? We're calling them hens. The people that will take you under their wing, that will follow up on you, that will make sure you got there, that will make sure that you feel seen, right? So there's just so many parts of it, but I really think that we really need to look at this link worker space and how do we facilitate the connections between the prescribers or the doctors that want to, utilize this in their work and the people who are offering. We have to build this middle, and that's the hardest thing to fund. It's the hardest thing that we're navigating it. And so
And to find,
yeah.
community health workers or link workers who can do this work. And for organizations to take a non-traditional approach to hiring the persons that we're talking about, because, in my experience, community health workers, link workers, they are all around us every single day. These are individuals who will do this work sometimes for free, and they are doing it in a lot of communities for free. There's an opportunity to impact workforce development when you think about working with community health workers and link workers. But I digress. What I'd love to get into a little bit is about metrics. So what do we use to actually measure the efficacy of the outcomes? I do want to go back to research, but right now I just want us to talk a little bit about, what do you guys measure? How do you know that this is actually working? And, how do you determine what the data is not saying when you look at the data? So I'd love to open that question over to Carla, if that's okay. I'd love to start with Carla.
Yeah, so this is a great question. And this is a complex one because, as a researcher nerd alert, like we can spend hours on talking about measurement, and ultimately it depends on what you're interested in. And I think many times we're measuring the wrong things. I think Camila was talking about using specific tools, and that's really important. So what I would say is, when you are looking at a program, think about, what are you trying to do for that person? Is it trying to help them feel more social connected? Is it trying to help their depression? So making sure that your measurement reflects what you're trying to do, one. And then also along those sides, make sure that you have a theoretical understanding of why you think it's working, because often what we see is a disconnect. Well, my program's not working. Well, is it not working, or are you measuring the wrong things? Or do you not understand what your program is actually doing? And I think, as Robert said, that's where we get into implementation. So what's fascinating in the world of social connection, there's a lot of different ways to measure things. And often we may have a program that's actually focused more on addressing social isolation, but it's not actually addressing loneliness, or vice versa. So being very clear on that. I think ultimately, whether we like it or not, and we're seeing more and more, I'm full of social commentary today, we are in a very capitalistic country where clearly finances matter. And so what many people want to see is that there's, the dreaded ROI term, like a return on investment, which I don't like that term, and I don't think we should use it to be talking about people, but such is life. But we want to see healthcare outcomes. Those are much bigger studies and much bigger things to look at, because you're looking at causation versus versus other types of relationships. But at the very basic of it is like, what are you studying? What are you interested in affecting? And what are the other potential variables, right? So if you are looking at loneliness, what about someone's depression alongside of that? So just make sure that you understand and have an idea of what you think your program should be doing. I'll start that as a basic thing, and I'm sure others have things to say.
Sure.
I can share a little bit of how we do it in our case. Well, we have some metrics in terms of coverage of our patients. So in depending on where we are, we have a different type of a population that we target. Initially with the social prescription, remember, we had to get people on the roll and how to do it and get involved. And so when we started, first was, how much of those people were we targeting? So if we were targeting the diabetics, how many of the diabetics were we actually reaching, that understanding how much they needed? And so it was about coverage. Right now in our Sanitas facilities, which is the partners that we do this with in Florida area, everyone has to have an SDOH, and the loneliness question is flagged in case that one shows up and nothing else shows up. You still have to get a social prescription. So we measure how many people that are coming in are getting the SDOH assessment, and then how many of those that are appearing as having a need get socially prescribed. So that's some of the first metrics we look at, so that we make sure that we're not leaving anyone behind. For us, that's very important. No one that comes out with a need should be left behind. And as Lenny was saying, we don't just send them out there. We only send out there those that are like empowered and are ready to do it by themselves. If not, the community health worker will hold their hand and go with them. Or as I say, keep the training wheels on top, and then make sure we do some activities within the facility so that we can connect those, especially that are not ready to go out on the jungle yet. And then from there, we have started measuring based on those social prescriptions. We have two measurements of outcomes. One is we're looking at the people when we assess them, if they came out with some sort of loneliness. Remember at the beginning we were just assessing loneliness, whether they costed the operation more or not. And I agree with Carla. I'm not a big fan of just doing it on numbers, but I do understand corporates want to see numbers. And so what we started doing is looking at how much did the people that were lonely versus those that weren't coming out lonely were costing our operation previous, so the 6 months previous to being assessed. What we found so far, and hopefully this research will be published this year, but what we found so far is that they're costing between 15 to 20% more if you're lonely than if you're not. And the higher costs are in hospital stays and ER visits. So definitely something to work around. And the more chronic conditions that you have, the more you cost, especially in those two areas. And then from there, what we're looking at right now is after you got that social prescription, and since we record everything and we know if you were taken by someone by hand or if you were just going, you went directly because we labeled them. We sent you directly, we held your hand, or you stayed with us. We know we can evaluate which was more effective. We are looking into the cost 6 months and 1 year after that social prescription to figure out if there's actually a return on investment of doing this. From very preliminary data that we saw, or that I saw, we did start seeing a decrease on the cost of those patients, especially in the ER visits because they were being more active. We started seeing an increase in some of the consult visits of going to the primary care, which was actually something good, because if you're going to your primary care provider, you're probably taking better care of yourself and not going to the ER when you shouldn't be going. And of course, the ER is always more expensive than going to a PCP visit. So that's the preliminary data. We are in the process of finishing the analysis and hopefully publishing some of that data this year.
Yeah, no, again, I thank you both for those answers. And Dr. Czar, did you want to chime in? I just want to make
Well,
sure.
yeah, I mean, it's a good question, and there's a lot of facets to it. When I think of outcomes and evidence, like building evidence, obviously my mind goes directly to the work that I do, which is these nature prescriptions, and it's largely among healthcare professionals. We do so as an organization, as a nonprofit. We're not privy to a lot of the any really of the PHI, so the protected health information, right? So we don't store any of that, and thereby alleviate some of the fears that physicians have in using our platform. But what we can see, every physician has an individual, every healthcare professional who's joined us has an individualized account. And with that individual account, they themselves can monitor every unique prescription. So there's no two prescriptions really alike. And each prescription has a place, an activity, a frequency, and a duration of time, meaning 30 minutes, 60 minutes, 2 hours, however, whatever they're going to do in that period of time. So that information is stored within electronic health records. So we don't have access to that, but we can see the number of prescriptions. We can see how many times a unique prescription has generated what we say a logged visit. So they filled a prescription, in other words. And that's exciting for us to be able to monitor that ourselves. We can see the growth of physicians or providers over time who've joined us. As I mentioned in my quick introduction, we have around 1,900 prescribers so far who've joined us from around the country. And they've, collectively prescribed around maybe 7,000 prescriptions, and they've generated collectively around 20,000 visits. So I would say, well, that's probably 20,000, probably more than would have happened. I can't prove that to you without doing a study. So there's that sort of we do use that to kind of gauge, how we're doing organizationally. PRA, my organization, has been partnering with other organizations. We're just finishing up now a partnership, a 5-year NIH R01 randomized trial on nature prescriptions with Dr. Deb Cohen, who's based in Kaiser Permanente, Southern California. Sorry, Alan, in the South there. And we were looking specifically at using these nature prescriptions among primary healthcare providers in a outpatient setting. It's a federally qualified health center based in Washington, D.C., and in kids between 6 and 16 years old, nearly 99% either eligible and enrolled in Medicaid, to give you some sense. Highly immigrant, very African American, very Hispanic, so lots of people of color and indigenous as well. So, that's to give you a sense of what we were doing for the last 4 years. And, collectively, I personally trained, over 100 providers, mostly physicians, throughout the organization. We had about 24 who ever prescribed because of having a patient who was a participant in the study. We had around 1,200 prescriptions generating about 18,000 visits. So just a massive amount just for the study alone. And we were looking primarily, our primary outcome was physical activity. So we used accelerometry, and the results, our publication right now is the results are embargoed because it's been submitted. But I can tell you that short term, we really saw some, for me, very positive results. So we saw an increase in physical activity, we saw an increase in park use, and we saw an increase in time spent in parks. So very exciting, right? From that. So this is sort of like, outcomes research. Very exciting to see that kind of result. As I mentioned earlier, we're also looking not just at patient outcomes, but the sort of implementation science piece. So being able to come back to you and say, okay, we've been doing this now for so many years, and we can see a dramatic rise in the number of providers who are prescribing. We can see a dramatic rise in the prescriptions that are being issued. We can see a dramatic rise in the number of prescriptions that are resulting in visits, like lots and lots of visits. That to me would be, also an area we need to be focusing quite a bit more on. And that goes back to my previous comment about, this why it's so hard, or what are the barriers, and what might be the motivations. And personally, I haven't given up on my colleagues around the country and around the world. I think there's something here, and this is something that I don't think Lenny or Camila had mentioned yet. But I just wanted to kind of point out that, to me, there's something potentially very reciprocal going on here. And I think oftentimes we think of clients as a direct object. They're out there and we do something to them, we refer them somewhere, which is an important part of the practice that we do. We do need to do that. However, I think that social prescriptions is unique and different from a lot of the other work that we do as providers. And when I say providers, I mean mental and behavioral health. I mean the whole range, okay? Like I would say nearly a third of our registrants are in mental behavioral health. So I'm not talking just physicians here. So a lot of professional counselors, a lot of therapists, social workers who've joined our platform. But my point is that I think there's some reciprocal relationship that goes on in the process of the social prescription. And I think there's something potentially to gain. And I'm all for the community link. I think it's a great thing. If you've got the money, you have a government who backs this, you have industry who backs this, you've got funding. I think it's great. Why not do that? But I think there might be some advantages and some pros to this. We might be losing if we go entirely toward that kind of model. I think maybe we're a mixed model would be interesting to me. And in fact, I've been working with a number of clinics and organizations around the country providing care when they say the providers don't have time. So we talk about the team, how can the medical assistant, how can the nurse, how can even the receptionist be part of this social prescription process within the uniqueness of their clinic setting. So I think there's something there that providers themselves might gain from this. It's a very positive thing. I think somebody suggested earlier what I like to think of as sort of asset planning instead of deficit. You asking your patients what like I think you mentioned, Lenny, the sort of deer in the headlines. Like where what do you see that's positive? What can you add to this conversation? What would you like to say? And that's really where we're going with this social prescription stuff. I think it's a different way of thinking rather than probably the general public's opinion of this is, oh, we're sending them to somewhere to get food, into a food bank, which is not necessarily all this is about. And I also will say, if I may, I know I'm going on a little too long here. You're about to cut me off, Tracy. is that social prescriptions are so varied, and we're not all speaking about the same thing all the time. So I'm trying to keep bringing up these general concepts of co-production, co-producing this, which I think are so important. And I think this element of reciprocity and potential gain, not just for the patient or client, but for the larger system, for the provider who's engaged in this process, it's a very positive experience in general, I think, for providers, from the research that we've seen so far.
Yeah, and I definitely don't want to cut you off, Robert. There's just so much information here, and it's so good. You guys are giving off so many good nuggets. I think from the beginning where we talked about the connection piece, then, thinking thoroughly around the appropriate metrics, the thought around ROI and whether or not ROI is the appropriate term to use. I do believe that it is important that we do define, social prescribing based on the audience, right? Who we're talking to. I think there's a collective opportunity for a hybrid, working in hospitals for many, many years. For some, it was the job of the social worker to basically, wipe the tears. I've been told that many times by many physicians, that's what you do, right? Versus, collectively saying, let's all have an interdisciplinary meeting and talk about how we're going to approach this family. So I think there's an aspect of learning there. That's a component that will actually maybe support some of the burnout that clinicians feel from working with clients, member patients. But where I'd love to go right now is just spend a little bit of time on talking about funding. How do you find funding for social prescribing? For those that may be on this call that are trying to implement a program or a pilot, what's the value? Where should they go? How can they go about looking for funding to support this kind of work?
I
That
wanted to
usually
say
is
that, oh, sorry.
the hard question. No, go ahead. I was going to say that's always a hard question. Go ahead.
I actually think that one thing that Robert said is incredibly important, that we start using, or we use uniform language and be clear about what we're doing, because I do worry that the term social prescribing can be used too loosely. And that will cheapen what we're doing, right? We will lose credibility if we're using it very randomly. So I think it's important to be very clear and thoughtful. And I don't know if I'm using the right terminology. And that's why I started by saying, like, I informally social prescribe, because what I was doing was not supported by a grand amount of evidence, but it was the right thing to do for the patient. That might be very different than formally prescribing things that have evidence. Maybe it does, or maybe it's not. But I think as we develop this field in the United States, having clarity around that is very important. And to not, let's highlight what we all do as individual organizations, individual people, but let's not also overstate what we're doing. I do not think I can cure all my ills for my one patient by playing bridge, but I do think it can accomplish a lot. And it may be that by playing that bridge, I may be more effective as a physician by then saying, like, okay, well, now let's control your blood pressure a little bit better. So let's be very clear in our intent and our purpose and our methods and what we are providing.
Thank you, Carla. I love that. Anyone else want to chime in on that?
I just
Well,
adding a couple of things really quick. As far as funding, I think that there are people who are getting creative. And I know that one of, the ways that we've been able to navigate our program is by meeting with, in our situation, it's with the Optum Medicaid team that's been our biggest champion, and saying, yeah, like, take some creative authorizations on those codes, and as long as you're billing them within that, like, we're 100% supportive of you, meeting the needs of clients in different ways and navigating that. So I think there are a lot of people who are getting creative with existing framework, and hopefully that creates the evidence base that we need to be able to expand that framework. And if there's mental health people out there that want to be like, give us a recipe, I will, sit down with me and I can walk you through that on my end for mental health. I want to double down on language. Super quick example is that I work with the Daring Way. I'm a certified Daring Way facilitator, which is the Brene Brown curriculum. And I've done a lot of trauma trainings for the Daring Way for clinicians. But I would say that the biggest advantage that I have, right, for people finding me through the Brene Brown curriculum and wanting to do therapy is that they show up in my office. And if she is like gifted at one thing, it is creating language, right? Like creating language around shame, vulnerability. And that person gets into my office, and instead of spending the first 4 sessions trying to figure out what the hell we actually mean when we're talking, it is like an immediate, this is what we're talking about. This is how we navigate this. And so I do think there's a need. While there is this magic and essentially like, yeah, like I can do social prescriptions for my kids and my friends, and there's this informality that we all know can matter. There really is something that has to happen as far as creating systems and language that we need to come together and in a unified way on these in order to move this movement forward, right? Like if I'm doing research in Utah with one set of language and someone else is doing it in another state, another set of language, how do we compile those results to mean something or to matter, right? And so although the inherent like value of what we're doing screams whether or not we're doing it in our homes or clinics or whatever, I do think that there is this need for like, we need to get firm on what does the system look like? What does the language look like? And then how do we take these elements, assimilate them, and get a movement going?
Yeah. No, I think that's so important, and I think that's a challenge. Because you go one state and, what you identify as the role of a social worker is one, versus in another state, it's a caseworker. In another state, it's a community health worker. It makes it challenging, I think, as you find governing bodies around this. We don't want too much overshadowing, but I come from a background where in the insurance space, NCQA governed a lot of the work that, in terms of creating standards around things. And I do think at some point there has to be, we have to think about what are some of those standards through the research that you find, not just something that someone who has no work with the community is deciding to measure. But there are a whole lot of questions that are coming from the audience. So I do want to shift for a moment and move over to the audience, if that's okay. While I
Can
do
I add a
that, and
little something though, Tracy? 1 second
sure, I
about
was
the
going to say
financing.
that while I find those questions, feel free, because Camilla, I could feel you coming through the screen. Like I felt
Well,
you wanted to say something.
yes, the thing is, I feel like research like the one I'm saying that I'm hopefully putting out this year is really about. So, as I said at the beginning, I'm lucky because I'm part of the health. I mean, I'm the nonprofit of a healthcare organization that's willing to do this with their own money and put the money into it and pay the community health workers. And they bought this idea even before they could start seeing any ROIs. Now they're seeing it 5 years or 7 years after implementation, but at the beginning, it's not. It's an investment, and that's how they saw it. But I know not all of the organizations, and I work closely with many of the insurance companies in the US because that's we are primary care providers. Our big company is a primary care provider in the US, and we've worked with many of those. And so I know the conversation is not easy. I think one of the crucial things of why we want to put research like this one out and others that are being done by Julianne Holustad, Carla, and many others that are doing this is how do we show that this actually does have an ROI? And I think once we show that, we need to start pushing as a group in terms of getting the healthcare sector to get involved and understand that this is actually costing them less and that they should be putting some bucks into this and financing some of this. And that it shouldn't just be a company like mine who understands this, that it should be everyone putting a little bit of that money that they're saving into this. Because at the end, the more activities that we have, the more parks that we can prescribe to, the more connections that we can make, the better it is for the health of every one of our patients, but also for, of course, the investments, financings, and ROIs of all of the healthcare companies.
Absolutely. I think so many of us need chief financial officers as a part of this work, helping us kind of really showcase what we're saving, because I think sometimes the language for those of us who are so passionate about this work, it becomes challenging to explain that because we're like, this is just the right thing to do. We're helping people's lives, you know. But for those that may sit in a C-suite, you know, that's the chief financial officer, it comes down to the bottom line. So I do want to say this. This is a question, Robert, directed to you. Do you feel some countries are more accepting of this compared to others? And they
I knew
want, I'm sorry?
I knew that was coming. Mhm.
You knew that was coming. Okay. And wonder if our belief and perception of healthcare is contributing to this.
Well, for those, I don't know who that person is, but if you know that I'm currently living in Canada, but practiced for most of my life in the US. Now I have, you know, a real life experience, both being a patient and a provider in two different countries. And you know, for those of you who know my other passion, you know, besides nature and health, it's really been healthcare policy and moving the U.S. closer to a single payer system as you know, as it is in Canada and Scotland and Taiwan, many other countries. And to try to answer your question, I mean, absolutely. I mean, I think, you know, it's quite evident that many other countries, you know, invest in a way that the US does not. And I think everybody probably in the audience, you know, and certainly the panel knows that, you know, in the US healthcare system is extremely wasteful and it's very for-profit driven. And, you know, I was listening to Lenny and Camila's comments on you know, saving money. But it's not, to me, it's not just about saving. It's fine to talk about ROI and talk about saving money, but probably more important for me is who's saving money in this and who's interested and not interested in saving money. And then that raises the question of where is sort of a national focus, or is there even a national focus on this? And this takes me back to really kind of like the financing specifically of healthcare in a national system. And we don't have that in the US. We don't have that. We have a very fragmented system. We have over 50% of the healthcare expenditures, which is way over 3 trillion now, is publicly financed. So it's through taxpayer money. You know, although that's the case, we still have way too many people in the millions who don't have access and don't have health insurance. And then we have to ask ourselves the question, well, who's benefiting from this? And I hate to say this, but I think, you know, we all know that the for-profit insurance industry is absolutely benefiting from this. So I think, you know, we need to think about systems. It's a hard time in the US to think about systems because our systems are completely falling apart. And it's scary right now for a lot of people. There's discussions of any upwards of $880 billion cuts in Medicaid. And you know, I've been talking about for years how innovative it would be to have a state Medicaid program endorse the kind of work that we're talking about. I think more specifically about nature prescriptions, and not just to, you know, endorse it as a concept, but pilot it and show these kinds of data that we're looking for. People often will separate the, you know, the implementation and the research into different buckets. But I think that, you know, there can be a lot gained from doing both at the same time. And I think a great way to do that is through waivers and pilots, to see what results you have before we say this is something we should endorse in a much, much larger way. But I think, you know, and this even coming back to social prescriptions and specifically nature prescriptions, is the work I do. You know, the question really, you know, is very much comes back to, you know, is this prevention or is this a treatment? Is it both really? And that helps to sort of, I think, frame where we might be able to understand the financial model around this. I've had many people say to me, well, you know, if we can't get it paid for, then how are we going to do this? And my response usually initially is, do we pay physicians to write medication prescriptions? And the answer is no, we don't. We pay for a visit. But I think a more relevant question really would be, if we are going to pay in that way, in that very sort of transactional model, what are we paying for? And are we paying doctors to do something that we think is the right thing to do? Are we paying for what happens on the receiving end when we send a patient, we send a client somewhere to have that connection, to have that experience? There is often an element of supplies that's needed, admittance fees that's needed to be able to do those kinds of things. And could the insurance industry, could the government, or could a combination of the insurance and the government be covering those kinds of costs? To me, that's also just as important to be able, when we're talking about funding, like, we got to make things practical and feasible and successful. I think we have to think about all of those things.
Absolutely. I mean, there's a component, as I think through the arts for anyone who is a performer, there's an aspect that we're now, generating and pushing, business, right, to the arts. So they need to sustain a life. They need to live. So there's aspects of that that has to be paid for as well. So it's a matter of, yes, who pays for it. But I definitely think coming from the background of working for an insurer, I saw the benefits to an insurance company to support incorporating this for the patient member client's overall wellness. So from a prevention standpoint, absolutely. But even just getting a person motivated to do some of the things to manage their health even better, and that speaks to Lenny's point around whether it's a link worker or a community health worker to support. I do have a few more questions, and I know we're getting close to time, but this is a very fundamental question, and it is, how do we get patients to try the arts, nature, etc., as many have tried so many treatments without results?
I'll jump in while others are thinking. I mean, I think it's just like anything else we do, it's sort of really playing into the whole stages of change model. Like, where are people, in that, where are they ready for that conversation? And sometimes they're pre-contemplative, sometimes they're contemplative, sometimes they're ready to take an action. So, you have a very limited amount of time, most of us do, with our clients. And so just kind of knowing where they are and then taking advantage of that opportunity in that time, in that way. And I think, like, I really very much believe in sort of a model that asks questions, really, and it's, going back to the asset framed model. So like asking them where they feel safe and comfortable to be outside of it's a nature prescription, rather than saying, oh, well, there's this great park I love, or I love listening to Beethoven. There's, the Fifth Symphony is playing tonight at the NAC. I think you should go too. Rather than that kind of language, really just asking some basic questions, just like we do. We ask, do you smoke? Do you skip meals? Do you have enough food in your fridge? Do you have breakfast? Things like that. There's very pointed questions, but you can ask questions that lead to the kinds of conversation that you're looking for, and it's a positive one, and one where actions could be taken, maybe not today, maybe the next visit, and that goes to Camila's point about primary care, that continuity of care and a relationship, and that longitudinal relationship that gives you opportunities to do that.
Yeah, definitely. I do have one more question. And it's a question that I think is really interesting. In your experience, have you or a loved one ever received a social prescription? And if yes, please describe. If not, do you think it had an impact on you or your loved one?
I mean, this is my inappropriate self-prescribing as a physician. So yes, I prescribe for myself all the time. The question is that, doctors are terrible patients. And so as I'm thinking here about, actually my own personal prescribing has been to try to take half of a wellness day on Wednesdays, which is doing some kind things for the soul, one of which is my yoga practice. And as I was thinking about, oh my God, do I want to chart till 1 a.m. or go to yoga? And I think it's going to be going to yoga. But so I would say yes, but I've never had that actually from my physicians to me do that. I have had mental health providers talk to me more about other things, but it's never been in the language of social prescribing. I have an older mother that I don't think has ever been prescribed anything formally. And you know, and a father who unfortunately died post-stroke and post-complications of severe depression from a stroke, that I probably, as the physician daughter, inappropriately prescribed for him also, or appropriately prescribed when his physicians were not, other ways to connect, which involved a lot around social connections and things that mattered to him. And that was his bonsai club, his cars and coffee club, his, you know, former professor lunch club, you name it club. What else? Clock repair club. So I encourage that in lieu of polypharmacy.
I would,
Thank you.
yeah, sorry, I'm gonna hop in. One of my favorite quotes is, sometimes you have to create what you want to be a part of. And I think, you know, I haven't received it from the outside in, but part of, you know, a Project Connection, we have about 60 employees. And the goal of what we're doing is, like, if we're gonna prescribe community, then we have to create community. And so it's been so fun. So we do these, you know, community events, and we have, you know, a really strong culture here, but there's also just this encouragement of people to create the things that they love and then invite other people to join. So just at our organization about mental health, we have our own book club. We have a hiking club. We go down to people that will go down to Southern Utah and go camping every spring and every fall. And so there are these, you know, things that are popping up within the agency as we're creating value around social prescribing for other people. And that has been so fun.
Yeah.
Yeah.
No, I love that. And I think what's interesting is, as leaders, you know, it is, and at least for me, it is important that when we feel comfortable to show our own vulnerability as leaders around how we are using the very things that we're prescribing. You know, I know that, you know, recently my husband had a procedure done. And one of the things I asked the physician is that, would you do this if this was your spouse, you know, if this was your partner? And, you know, one of the things he said was, absolutely, yes. And it gave me a level of certainty in some regards, right? So I think as leaders, sometimes it is important that we kind of talk about how we are utilizing social prescriptions as well for our own mental health to address burnout and the like. Many times the best advocates of things are people who have gone through something, and they use their voice as a microphone to bring power to that. Any final words from our panelists? I mean, I think this was a great panel discussion. I think we could probably go on. We do have 5 minutes remaining, but I would just love to hear if there are any final words that anyone wants to add just about the social prescribing movement, what their goal and what they hope for. When we come back next year, 2026, to do this, what will we hope to see?
I'd just like to say this has been a great conversation. I've really enjoyed it, and I love the questions as well. You know, and I would say, you know, maybe one parting thought for me would be, you know, to think not just about our clients and, you know, and our communities in that sense, but to really remember our colleagues, and the work that we're all trying to do together. And I like to use that number, the 18 million healthcare professionals in the U.S., all of us together trying. You know, like there's so much terrible things happening in the world, and I go to work. I worked last night in the ED, and I came home. My kid was like, "How was your shift, Daddy?" And I was like, you know, it's just it's like an element of humanity, you know, when I have an opportunity to be there amongst colleagues who are trying to do the best for other people, to help people in that way. And that's what we're trying to do here. We're trying to be innovative and find, you know, the best ways with the best evidence. And let's remember our colleagues who are there with us, who may not be, you know, well versed in this language that we've been immersed in for so long now, and to think of ways to do that. And you know, I a few years ago became a nature therapy certified nature therapy guide, and will take my colleagues on a 2.5 hour experience when they have time to do it during a retreat or whatnot. So I would encourage everybody on the call, like, think about your colleagues, think about your neighbors, think about your, you know, people, you know, in your community, and what might you do for them, to kind of spread the word in that very personal, intimate way.
Yeah, no, thank you so much, Dr. Czar. I mean, I couldn't think of a better way to end on a no, such a high note. I want to pass it over to Alan, but thank you guys for allowing me to moderate this. I had a wonderful experience with all of you. With that, Alan?
Yeah, it's just been such a rich conversation and also following the chat and just all the input from people who are here. Um, I love that is really concentrating on the staff. I've thought about like how do we do this with the staff because I think the only way to really get people to prescribe this frequently is to have the staff experience it. So I'm definitely looking at that even in my own work. There was just so much. I mean, yeah, funding and the idea of trying out different models. I just really look forward to continuing these conversations with everybody. It's going to take definitely a village to try to move this work. So thank you for everybody, all of our panels and the people who attended today. You'll be getting a follow-up email with resources and a link to be able to watch the webinar for those who aren't here. They'll be able to get that. Definitely stay connected at Social Prescribing USA on social media and the website, socialprescribingusa.com. We just got a new website in January. And one of the I saw some people asking questions around evidence, and we're really trying to house a lot of that evidence on our website. So if you take a look there, it's really divided by different interventions, by nature, by movement, and then the economic part of it as well. So take a look and see, and you might be able to find some of the answers you're looking for there. We have a lot to learn from other countries, and thankfully they are providing it. But a lot of this is going to need to be done in the U.S., especially around the ROI that you mentioned. So there are a couple more programs at 2 o'clock. There's a all hands meeting with Jules and ourselves. So where people can really think about what can they do to help move social prescribing forward. And then on Friday, March 21st, the social prescribing, a snapshot from the field from the Federal Reserve Bank of New York. And so you can register. I think he's put the link in the chat. And so check out all these other things. And we really appreciate people being part of Social Prescribing Day 2025. It's amazing to see what's happened since last year when we first celebrated this. So thank you all, and let's continue the conversation.